You can take it away, Dr. Puravath.
Thanks, Janet. Good morning, everyone. Welcome to the third session of this year's VIP adult webinar series. I'm delighted to be here and to moderate this first talk. Just some housekeeping rules before we begin. Please remain muted throughout the webinar. I will review your questions and present them, and please make sure to submit them through the Q&A. The chat is intended for general comments that everyone can see, and raise your hand or use the raise hand function to notify the host that you may need something and they can respond to you in a private chat as well. So let me introduce Dr. Mark Hwang, the lecturer for today's topic of spondyloarthritis. He is the assistant professor of medicine at McGovern School of Medicine, University of Texas Health Science Center, UT Houston. He studies spondyloarthritis. He's the co-director of the UT Health Spondyloarthritis program. He's an active member of the ACR, of Spartan, and GRAPPA. And he was just recently awarded the Jane Bruckle Early Career Investigator Award by the Spondylitis Association of America in 2021. And he has completed the KL2 Scholar Program from UT Health and MD Anderson for Clinical and Translation Sciences. He is also my former mentor, colleague, and friend, so I'm delighted to introduce him. And without further ado, Mark, the webinar is yours.
Thank you so much, Dr. Puravath. And I'd like to begin by thanking the ACR for this opportunity to talk to all the new fellows, wherever you are around the country or the world. I just wanted to say that I think you guys have made a fantastic decision going into choosing rheumatology. And it's an honor for me to give you this lecture among my friends and colleagues. Surprisingly, I currently have no relevant financial disclosures. And here are our key topics for the day. So to address those three areas, I thought it'd be nice to have a general overview with a concentration on clinical manifestations. Because when I thought back to when I was beginning my journey in rheumatology, I remember how difficult it was trying to learn these different diseases. I hope our lecture in this organization helps you out today. So spondyloarthritis or spondyloarthritis are core rheumatic diseases that we treat in rheumatology, as you can see from this photo on the right in our Rheumatic Disease Awareness Month flyers from the ACR. They have various names you'll come across in the literature, including seronegative spondyloarthropathies, Petru's disease, Murray-Strumple. The common term and more standard term is spondyloarthritis now. They encompass various related diseases, as you can see here. Over time, the concept of SPA has evolved, where currently, depending if we're lumping or splitting, we tend to go by manifestations of disease, whether they be primarily in the axial skeleton or primarily of the peripheral skeleton, as you can see aligned here. Axial spondyloarthritis, which includes ankylosing spondylitis and non-radiographic axSpA, tends to happen a little bit earlier than some of the other inflammatory arthritis you see, such as rheumatoid arthritis, where generally the age of onset tends to be in early adulthood, below the ages of 40, 45. Again, this slide is just to show you, while we can think of these as different diseases, and they have their own idiosyncrasies and important details you'll learn over time, it's helpful to, when you're first learning these, think of them primarily by their manifestation. And that's how they've been classified to really help study these diseases, with the quintessential example of axial disease being ankylosing spondylitis. Spondyloarthritis closely follows genetics, where HLA-B27 positivity, as pictured here around the world, actually mirrors the prevalence of spondyloarthritis as well. So particularly in North America, Europe, and East Asia, we see quite a bit of this disease. The clinical manifestations are numerous, where they can involve different organ systems, primarily the axial skeleton, the peripheral skeleton, as well as extramusculoskeletal features that involve the eye, gut, and skin. But there can also be cardiac, pulmonary manifestations as well, that due to time purposes, we won't be able to cover today. The big detail here in this photo taken from our next lecture, my friend and mentor, Dr. Alexis Ogdie, that this disease is a multi-system disease, and the impact really does decrease health-related quality of life, can cause mental health disturbances, of course, and reduces work productivity and has increased work disability. So with axial manifestations of spondyloarthritis, the classic example is this Canadian soldier, as you can see over the 30 years, where he starts young and fit, and of course develops these structural changes of his spine, where he's unable to really raise his head, has this horizon gaze where he has to really look up to see. And while this is the classic example, this doesn't really happen to all our patients who have axial spondyloarthritis. We know that more in this natural history of axial spondyloarthritis, there are patients who have the inflammatory disease burden, which is similar to those who have these structural changes, but they could be persistently in this non-radiographic or not having structural changes seen on x-rays, as well as people with AS can have progression of their spinal disease, as you saw in the photo before, while some have virtually no spine disease at all. From our talk today, I like to concentrate on these 4 areas that I think are quintessential and very representative of axial spondyloarthritis. Interesting, chest pain happens quite a bit in axial SPA, whether this is due to inflammatory manifestations of enthesitis, costochondritis, or inflammation of the sternocleidomastoidal joint. They can all manifest in this very unique sort of presentation that happens in a 30 to 40% of our patients with axial spondyloarthritis. It certainly can be the presenting symptom, so it's important to file in the back of your mind. Inflammatory back pain, however, is the quintessential example of axial spondyloarthritis. There's been various criteria over time to help codify this, but the important takeaway from these different criteria are that this tends to happen chronic back pain in a young persons under the age of 40, 45, 50. That's very insidious on onset, and paradoxically, it seems improved by exercise and either worsened by rest associated with stiffness are signs that this may be something different than some of the non-specific or mechanical back pain you've seen a lot during your internal medicine or family medicine training. Perhaps the best way to really identify inflammatory back pain in your mind is to juxtapose it against mechanical disease. So we know mechanical disease is very ubiquitous, particularly in the United States, where it affects up to 30 to 40% of the adult population. We know mechanical disease is not necessarily associated with imaging each time, where it's a smaller percentage that we can find that lesion that identifies that problem. And so you have inflammatory, which tends to happen in your younger population, versus mechanical, which happens more into the middle to late years. Mechanical can be more acute in onset, and alleviating aggravating factors are the complete opposite of inflammatory disease. So improved with rest or the supine position may be more exemptions from mechanical. So while you're building this construct of inflammatory back pain in your mind, try to hit all these different areas and see, as you build that armamentarium illness scripts when you're studying this and treating these patients, of how these compare and contrast. So structural changes in axial spondyloarthritis are a very striking phenomenon. The proposed sequence, which may be a little reductive, however, I think is a good way to kind of build your knowledge, is that we know that where we see inflammatory erosive changes in the spine and the sacroiliac joints, there may be, after this damage, this new repair and aberrant bone formation with repair that causes some of these striking details, such as ankylosis that you see here. How to best really see these changes from a clinical standpoint is by imaging. Main imaging in axial spondyloarthritis consists clinically, at this point in time, consists of radiographs and MRI, where radiographs are obviously an older technology, but they give us a lot of information about structural changes of the sacroiliac joint and the spine. MRI similarly gives us information about some of the structural changes at roughly equal levels to radiographs, but also can capture more active lesions, inflammatory lesions, mainly consisting of bone marrow edema, synovitis, and capsulitis in the SI joint, and particularly bone marrow edema of the vertebral body. These are very sensitive studies, so the interpretation can be tricky, which hopefully we'll discuss a little more right now. There's been various ways and standards to quantify the changes in the SI joint and spine with these different imaging modalities. Other imaging modalities are to note that are currently being used more in the research realm include CT scans, as you can see below, with low-dose CT of interesting use where it's better at capturing some of the structural changes you see in the spine. And so while we compare kind of the millisieverts of radiation exposure, we'll see if this makes its way over more into the clinical realm. PET CT, dual energy CT are interesting as they also are able to capture inflammatory lesions, similar to MRI to some degree. So first, we're going to cover radiographic sacroiliitis in details. So as you saw in a couple slides before, erosion, sclerosis, and really joint width changes of the SI joints are some of the structural changes you'll see. This, in the setting of chronic lower back pain, inflammatory back pain, starting with imaging of the SI joint is very important. And while this grading schema can get a little convoluted, I think there's some anchors that can help us out. First, grade 0 is just normal SI joints. So being able to see that you can visualize the SI joint, the caliber is fairly uniform from top to bottom, that you don't see erosions, a lot of sclerotic changes, or loss of that joint space, ankylosis, helps distinguish that these are normal SI joints. As opposed to the most severe manifestation of SI joint disease, total ankylosis, where everything I just talked about, you don't see, where you just can't see the SI joints. They are not there. Where it gets a little more tricky is with grade 3, which is definitive disease, where when we see partial ankylosis, where when you look on the right side of this radiograph, you can't distinguish the SI joint, particularly over the anterior portions of the inferior portions. You see erosive changes where you see the ragged edges of the joint, particularly on the left. And that helps show you that this is grade 3 disease on both sides. For grades 1 and 2, this is where it may take a little more subtlety. For grade 2, which you see more representative on the right, there's a little bit of pseudo-widening of the SI joint, which is not that the diatheses of the joint have loosened, that there's loss of subchondral bone due to erosive disease that shows the caliber is different from the bottom to top. On the right side, you don't see that, where you do see a little bit of sclerosis of the subchondral bone, the bone that's right next to the joint itself. And so that is a general schema of looking at disease of the SI joint in an axial spondyloarthritis. Moving on to radiographic spinal disease. Here you're looking more for some of the phrases that you've hopefully become familiar with, though it's hard to say in the beginning. We're looking at erosions, so real loss of that subchondral bone line, as you can see at the top right here. You can see squaring of the vertebral joint where there's loss of that concavity of the vertebral body in the corners. And you can see growth of syndesmophytes, which take quite a bit of nuance to understand, where these are coming from the corners specifically, tending to not be too angulated, not angulated over the corners, which would be more common seen in osteophytes and other diseases. And these can be present or cause total bone bridging of different vertebral bodies in the spine. Looking for these changes is important, and patients are very interested, where of course they have fear of having those most striking sort of obvious structural disease. So while there's no true, from a clinical standpoint, timing of how often to do this, where this has to be weighed against the risk of that radiation exposure, in our clinical practice, we tend to do these in a fairly regular basis, but generally waiting at least 2 years between getting radiographs, depending on our next area. So next, we'll move on to talking about MRI imaging in axial spondyloarthritis, where in the SI joint in the spine, we can see these changes in their respective area. When we look at MRIs of the SI joint, we do want to look for active disease. While we can see things like capsulitis, which is outside of the true joint here at the top, we can see enthesitis, or the tendon attachment from the muscle to bone, coming in on different slides of this MRI, and as well as joint fluid, which we can see a little bit better on this side, on this side here in the true joint. Seeing bone marrow edema, this intense signaling on STIR imaging or fat suppressed fluid sensitive imaging on MRI that involves the subchondral bone, is the most striking for active lesions in ankylosing spondylitis and non-radiographic axSpA. It is important here to note that we can see fluid physiologically as well, particularly in active patients, runners, basketball players, soccer players. So seeing these in multiple slides and associated with structural changes may be a little bit more diagnostic for the presence of axial spondyloarthritis. And here you see examples of those structural changes. So this here is T1 imaging each time. And the structural lesions, we see erosions, ankylosis, similar to what we saw on X-rays. However, here we also see fatty metaplasia and fat lesions of areas of previous chronic inflammation. There can be physiological fat, of course, in the SI joints. So involving the subchondral bone really being associated with these structural changes help make it a little bit more specific for axial spondyloarthritis. Spinal lesions are hard, where on MRI, this is a very sensitive study, and I think there's a tremendous amount of information we are both receiving and learning to interpret in MRI spine. We can certainly see similar structural lesions like we saw both on the SI joints and in X-rays of the spine. But particularly, I think the big takeaway here is that you want to see that the vertebral body corners here, where the arrows are indicated, are involved to say this is more likely to be associated with active spondyloarthritis each time. Where while we can see involvement of the posterior portions of the vertebral bodies or anterior, we also can see costovertebral joint or facet joint involvement. However, interpreting this in the setting of various stresses on the spine is hard. So takeaway on this slide, I do want you guys to remember that you want to see multiple levels, 3 or more, of spondylitis or inflammation of the vertebral body corners to really see if this is more associated with disease. So we talked a lot about imaging, and we showed you some of the structural changes we saw in axial spondyloarthritis. I also wanted to talk a little bit then, part of your clinical exam that you can do that's looking at spinal axial mobility. It's important to note again that while we can intuitively understand if there are a lot of structural lesion changes of the spine, there's going to be some restricted range of motion. However, independent of these structural changes, studies have shown that active disease, so where we see those inflammatory lesions, having high disease activity as measured by our patient-reported outcomes, are associated and correlate with restricted range of motion. In fact, when I've looked at this in some of our observational cohort studies over time, those changes that are more than just measurement error that are seen time in repeated measurements over 6 months to years, sometimes don't have any different structural changes, but really are just purely from active disease. So this can be helpful to if you're getting sort of a unclear picture from your clinical encounter. And here are some of the examples of spinal mobility measures we use in clinic, where cervical rotation using a compass for the C-spine, occiput to wall, which is just your occiput to wall standing straight, or tragus to wall can be helpful to measure the thoracic spine along with chest expansion. And then doing a Schober's or modified Schober's, as well as lateral lumbar flexion in a plane against the wall, can tell you a little bit of how well patients are moving compared to norms. So that covers in a fairly timely manner what the axial symptoms that are a little bit more exemplars of axial spondyloarthritis or axial manifestations of spondyloarthritis are. Of course, there are peripheral skeletal manifestations as well that I know are going to be covered in great detail during your next lecture on psoriatic arthritis. I just wanted to briefly mention a couple things in this area for you right now, in that hip disease, which technically is not a part of the axial skeleton, is very, very common in axial spondyloarthritis, where up to 30 to 40% of patients can have hip disease. There are some differences compared to more osteoarthritis of the hip. Certainly younger patients having bone marrow edema in certain subcortical, subchondral bone areas on MRI are seen. This is just something we should be aware of, as the effectiveness of treating this is not well studied. And if this can cause obviously a lot of functional issues that may require total hip replacement at a fairly early age. Peripheral arthritis is seen in approximately 20% of axial spondyloarthritis patients, and of course in our more peripheral spondyloarthritis patients, seen almost 100% of the time. It has a predilection for the lower extremities, but can involve almost any joint, not necessarily in a symmetric pattern. Enthesitis, which we mentioned briefly earlier, is anywhere you have tendon attachment onto bone. The Achilles insertion really on the calcaneus, not in that kind of medial area that's a little bit above, is a pretty specific area for enthesitis. There are various indices and measurements we can take on a clinic-to-clinic basis. And I think whichever standard you pick, as long as you use it consistently, it can be a helpful sort of measure for how well your treatment is working, how well your patients in combination with the other measures you're getting. Dactylitis, of course, is digit swelling of the hands or feet, as you can see in this photo here. Okay, now we're moving on to extra musculoskeletal manifestations in ankylosing spondylitis. These are very common, where the prevalence is over 40% during the lifetimes of patients with spondyloarthritis, mainly broken down into 3 areas: anterior uveitis, psoriasis, or inflammatory bowel disease. This is particularly true for ankylosing spondylitis. These diseases themselves may be a manifestation of spondyloarthritis. Talking about them in particular, uveitis and spondyloarthritis is an area of high interest to me, mainly because my lovely and brilliant wife is an ophthalmologist, so this is an area that I can have great discourse on. So in spondyloarthritis, acute anterior uveitis is the most common manifestation. We also see these to a lesser degree in inflammatory bowel disease associated in psoriatic arthritis, examples of SPA, which also can manifest more in a chronic intermediate posterior uveitis phenomenon. With anterior uveitis, you'll get a history of patients reporting mostly unilateral pain, photophobia, blurred vision, and redness of their eye. What you can see on your physical exam that probably won't involve an indirect. There's certainly, if you guys are skilled with an indirect, that would be great as well. I am not. I've tried. The exam findings you can see of just grossly staring at the eye are the following for anterior uveitis. Synechia, which are, if you look in the topmost photo on the right, you see the pupil is a little distorted. That's because the inflammation prevents the parts of the uvea, which are the choroid, ciliary body, iris, the iris from contracting properly, so you can't accommodate light very well. Instead, due to this inflammation, you get these irregular shapes, which you can observe if you're staring closely. You can see the ciliary injection, or this very round limbus around the eye. That tends to not happen as much in sort of your allergic conjunctivitis and other issues. So that could be something that can help you determine if this is anterior uveitis. Hypopneon, or that purulent material you see in this middle photo that collects at the base of the eye, is seen quite a bit with HLA-B27 associated, independent of SPA, and SPA as well. And these recurrent inflammatory episodes can cause fibrin deposition, which we see in the bottom photo here, that accumulates over the iris, accumulates with the iris. You do need to think of other diseases, particularly viral Behçet's disease, when we're considering inflammation of the eye. But given how common this extra-articular musculoskeletal manifestation is, I highly suggest you know your local uveitis of ophthalmology experts, retina experts, and have a good working relationship with them, as I hopefully do in Houston. Skin manifestations of spondyloarthritis are common as well. Psoriasis being the most quintessential example. That, of course, is going to be covered in great detail over the next hour. Palmar pustular and plaque psoriasis, as from these 2 photos here, are some of the most common seen in spondyloarthritis. More rare skin manifestations include erythema nodosum, pyoderma, and keratoderma, as you can see in these photos. GI involvement in spondyloarthritis is a fascinating area. The gut joint hypothesis, which we don't have too much, that may cause some of the pathogenesis of this disease, strongly supports this clinical finding then of, in a lot of our patients with axial spondyloarthritis, while only a small percentage have true overlap disease with inflammatory bowel disease, which this photo is more representative on the right. Almost a large percentage of patients, when we look on colonoscopy, may have a subclinical colitis, microscopic or otherwise. So if your patients with spondyloarthritis are complaining of bowel symptoms, it may be worthwhile to have them referred to GI to see if they need a colonoscopy, because that can change your management of their conditions if they're having these overlap manifestations that are responsive to treatment. When you think of it from the flip side in inflammatory bowel disease, while not a lot of patients necessarily complain about inflammatory back pain, though they can, where about 5% of patients have axial spondyloarthritis and IBD or non-radiographic axial, almost 20% can have occult sacroiliitis seen on our imaging modalities we talked about earlier. So just keep that in mind when we're thinking about these diseases. So now that we've gone over some quintessential examples of axial spondyloarthritis and spondyloarthritis in general, I'm going to do something that I don't know if you expected, but one of my favorite things to do, given the nerd that I am, talk about math. So why I think this is so important is, if you are familiar, and that's awesome if you are, as a clinician, you're really using Bayesian or Bayes theorem in clinic, where you have some thought processes based on your history of the likelihood of disease. If you can organize that pretest probability, use these manifestations, imaging, lab findings to really then take your pretest probability, interpret those results, and come up with a post-test probability of your certainty or uncertainty of disease. Codifying that, thinking about that, puts you both from, as you gain experience in that type 1 Kahneman-Tversky learning of being that master clinician, recognizing those illness scripts, but also being a little more analytical in the type 2 method of taking those patients who are coming in with this chronic back pain, organizing your thoughts on how these manifestations, as you go through them, change your likelihood of having disease, and then coming up with some sort of posterior probability each time of the likelihood that patients have it, which can then help you gauge the threshold on which to treat your patients, given that there will be this world of gray that you're not necessarily sure they have disease, but you have some suspicion due to their symptoms. It's been proposed that a cutoff of 90% would be a comfortable cutoff for diagnosis of disease. It's an individual comfort level, of course, over time, as I think your pretest probability and recognition of this disease certainly will improve as you experience it more and more. So we've talked a lot about diagnosis. We'll now move on to our second key topic, which is classification criteria. So classification criteria are a great tool where they help create a homogeneous patient population that allows us to study disease, look for treatments, and really from that research aspect are very helpful. They are helpful when you're learning these diseases as well, where they're a scaffold to build your knowledge off on each time. What I want to emphasize is these are not the end all be all, of course, of diagnosing disease, which we've spent over the last half hour talking about. So it's important to know these classification criteria and understand their purposes as well. Sorry to get on my soapbox there. So first, starting with classification criteria for ankylosing spondylitis. So this is a combination of clinical criteria and radiographic disease of the sacroiliac joint, as you can see here. So you definitively have ankylosing spondylosis if you have the radiographic phenomenon with one of these clinical criteria listed of inflammatory type back pain, limited spinal mobility, particularly the lumbar spine, or limited chest expansion. based on your age, gender. Based on your age and gender, that measures the thoracic sign more so. And that's our oldest and most well-established form of spondyloarthritis. Over time, of course, with new imaging, we are definitely capturing more patients with this spectrum of disease. So from the Assessment of Spondyloarthritis International Study, ASIS, they've codified classification criteria for axial spondyloarthritis, which can be imaging-based or pure clinic-based from having imaging that can be seen on X-ray or MRI. On MRI, that's particularly having bone marrow edema at least 2 slices of your sacroiliac MRI imaging. Or it can be just having that HLA-B27 positivity and having 2 features as listed here. The overall sensitivity and specificity in looking at patients specifically with back pain was pretty good. We're over 80% sensitivity and 84% specificity when looking at European populations. For peripheral spondyloarthritis, this is where you have one of those peripheral manifestations of inflammatory arthritis, enthesitis, or dactylitis, plus having some of these spa features listed here. The sensitivity and specificity are a little lower, but still better than pretty good discrimination as well, with a sensitivity of almost 80% and specificity slightly over 80%. Those are the big 3 classification criteria I want you guys to be aware of for spondyloarthritis. And they can be helpful, again, of course, when you're trying to enroll patients into clinical trials to see if they'll qualify, but or for study for your own purposes. But if you use them in the beginning to help recognize these features, understanding they are not the end all be all in terms of diagnosis, I think that can be quite helpful. That's all I really wanted to say about classification criteria. In our last few minutes, we're going to talk about clinical care. So the biggest thing I want to emphasize here is that in addition to pharmacological interventions, physical therapy and exercise are very important. In the 2019 treatment guidelines from the ACR, Spartan and Spondyloarthritis Association of America, we see that exercise, structured exercise, active, and exercise in general are recommended as treatment for axial spondyloarthritis at all stages of disease. This is due to a quite a well-established number of trials, interventions over time that show strength, flexibility, stretching, and posture are important aspects to improving ankylosing spondylitis manifestations of mobility, even disease activity, including pain, stiffness, and as well for general cardiovascular health. We see that exercise versus no intervention or versus kind of structured exercise versus usual care over these RTCs when combining these data have a definitive clinically important difference each time. In this meta-analysis here, we also see that looking at these studies over the last 15 to 20 years, there's a definitive response to medications that's fairly robust. Not all exercise is equal, where thinking about these different categories of cardiovascular, muscle strength, flexibility, and postural are important, as recommended by the American College of Sports Medicine. The WHL also recommends more postural stretching. When I talk about exercise with my patients, I do tend to concentrate in these 3 areas, where looking at postural and mobility, strengthening and cardiovascular are important, in addition to my pharmacological measurements each time, the interventions each time. Where we know from a movement perspective, it can be quite helpful, regardless of where you are from a structural progression standpoint. And even when using outcome measures that are a little bit, that incorporate C-reactive protein or erythrocyte segmentation rate, you see improvement in these different domains of axial spondyloarthritis with exercise. We do know that patients with this disease may have more MACE events, so good cardiovascular fitness is important as well. So in all your patients with spondyloarthritis, please think about exercise. We'll now move on to more of our pharmacological interventions. Sorry about that. Okay, so the first line therapy for active disease are nonsteroidals, where nonsteroidals have a definitive treatment effect on this disease. Continuous use of NSAIDs at their maximum dose is preferred over as needed when you have active disease each time. If you have peripheral or isolated hip disease, local glucocorticoids can be considered. Synthetic DMARDs, such as sulfasalazine, are also useful for peripheral dominant disease. If you fail NSAIDs, and I would personally recommend cycling through more than one, though we leave that up to you, where generally a trial of 2 weeks to a month is enough to see if patients will have an effect from those medications, depending on their half-lives. You do then want to look at your biologic therapies. TNF inhibitors are the main class to really consider, given our experience with them, the over 20-year pharmacovigilance that's happened on these medications in different diseases, and their overall their effectiveness in treating spondyloarthritis. If you fail TNF inhibitors, since 2015, we've had more information about interleukin-17A inhibitors, which is why from an ACR Spondyloarthritis Society's perspective, we recommend these medications as well, because there may be a little more chance of responding to a different class of medication if you fail TNF inhibitors in the beginning. And then tofacitinib and now upadacitinib, that was FDA approved for the treatment of spondyloarthritis over this past year, are another class of medications that are efficacious in this disease process. Given the black box warning for MACE events, further study, and I do think in the next treatment recommendations, this will help clarify where the role of these medications are. One note of caution I'd like to talk about with these, particularly interleukin-17A inhibitors, there were some concerns that would cause an unmasking of inflammatory bowel disease when they were first came to market. So while I don't know if that, and there's been mixed data if this is a true effect or not, you just want to be mindful of that when considering these medications in your patients who have inflammatory bowel disease, which I do use with caution. So we've talked now very quickly, and I'm sure you're going to go over this in more detail as you progress through your fellowship on those medications. If you have stable disease, which generally is having disease that's in a low disease state or a patient acceptable symptom state based on some of our disease activity and functionality measures, you can then think about nonsteroidals on demand. If they have advanced hip arthritis but have no active symptoms, considering surgical interventions. And if they're stable on biologic medications, we do recommend at this point in time continuing them as opposed to discontinuing them. There's more research that's gone into looking at tapering or reduced doses on these medications that we're still continuing to learn about at this point in time. So that really concludes all I have time to tell you about today. So in summary, spondyloarthritis is a multi-system inflammatory disease. Classification criteria are helpful to really help us study interventions and to understand this disease process, and can be a scaffold for you to learn these diseases. But the diagnosis involves a combination of symptoms, exam findings, imaging, and lab values that you develop your own style. And as you learn more about this disease, will make you an expert, I'm sure, in diagnosing these. Always consider exercise in patients with spondyloarthritis and continue to follow along, as there is a growing armamentarium of pharmacological treatments to help our patients with SPA. Again, I'd like to thank the American College of Rheumatology, particularly those on the virtual adult rheumatology program, everyone for their intention, the Assessment of Spondyloarthritis International Society for their wonderful slides, and all our funders and my mentor, Dr. John Ravel, who's pictured here, as long as our wonderful faculty that are part of the UT Health Spondyloarthritis program.
Thank you so much, Mark, for speaking about this very important topic. I just wanted to go through some of the questions that were in the Q&A. One of them was, has there been a comparison between using ultrasound for imaging compared with MRI or CT? Wasn't specified in terms of what joint, but if you had any thoughts on that.
That's an excellent question. So for the peripheral skeleton, ultrasound has a very large role, where in the next following lecture, you're going to hear about ultrasound and measuring enthesitis in particular in psoriatic arthritis and peripheral spondyloarthritis. Part of the problem with ultrasound currently for axial disease is the penetrance, where you really need, the technology is still catching up at this point of using ultrasound for deep structures like the sacroiliac joint, which is why it perhaps hasn't been studied as much. That is certainly, as the technology improves, something that we're going to have to continue to study, as it's a little bit more ubiquitous in clinic. It's something you can do, and something definitely I encourage.
Awesome, thank you so much. Another question that I had is, now it's very common to see patients where they may get imaging such as an MRI before being evaluated by a rheumatologist. And the problem is, you speak with that patient and they don't have any evidence of inflammatory back pain, but they may have MRI changes that are concerning for sacroiliitis or some other manifestation of disease on imaging. How do you handle such a patient?
That's a great question, and a clinical scenario I do think we're going to see more and more of. I think there are a couple of takeaways from that, where in general, they've probably gotten this imaging due to some symptom, not necessarily inflammatory back pain, which, if you think of conceptually, your questions are, if you use the classic elephant and feeling the different parts of the elephant sort of example. So your questions are pointing you to that area, but those sort of questions on inflammatory back pain, how well do they really capture this concept? How stable are these questions in different patient populations, such as the elderly versus the young? We don't know very well, truthfully. So when I come across, sorry, back to your real question, of patients who have imaging, and I look for how strong that imaging is. So did they have multiple layers of this MRI that had true bone marrow edema that involved the subchondral bone? Do they have erosive changes that are involved here, are involved and associated with this edema each time? So the specificity increases, of course, the more findings you have on your MRI. So doing a deep dive of what's considered positive of MRI is very important. I think secondly is, if they are positive, but you don't feel they have any other true features of spondyloarthritis, so just having isolated sacroiliitis, it may be okay to monitor them. So having close follow-up, really probing them to see if they're developing any spondyloarthritis specific features that can justify starting a treatment algorithm is very important. So I think, sorry, that was a very long answer. In short, If they truly have isolated sacroiliitis, you can consider local corticosteroid injections, observation, but they are someone you need to follow very closely, would be my suggestion.
Very fair. I think that's all we have in the Q&A. I have one more question since we have a little bit of time, which is your thoughts on both infectious etiologies for sacroiliitis, as well as and this wasn't discussed in too much detail in this talk due to time limitations, of course, but this concept of using extended antibiotic therapies in a reactive arthritis that may have had a clear infectious nidus.
That's a very interesting question, my friend. And I don't know if, truthfully, I have a great answer for you. Certainly, we know there are many infectious etiologies that can cause inflammation of the sacroiliac joint. They're going to have features that may not be as spa-specific. So not necessarily involving the subchondral bone, having kind of that extended areas of inflammation outside of the SI joint, more in the hip as well for osteomyelitis, are perhaps, and getting a good history to see if there's been a penetrating trauma exposures are important. The classic brucellosis case that you'll hear occasionally from an oldest script is something that stands out in my mind in particular. Extended antibiotics are interesting, where certainly those are used in some of these overlap diseases. We didn't have a chance to talk about Sappho syndrome or CRMO, where those have been looked at before. I think that if it's justified from an infectious etiology standpoint, that may be a reasonable treatment algorithm. However, especially with reactive arthritis, that's now chronic, so more than a couple of months, I tend to treat more as just a pure axial or peripheral spondyloarthritis patient and use our immunomodulating therapy, immunosuppressive medications.
That's great. Thank you so much. I think then that will wrap up this section of the talk.
I have a quick question.
Oh, go ahead.
I'm sorry. So I'm going to use my patient scenario, a patient who came in with inflammatory joint pain, as well as inflammatory back pain, but her back was the more problematic of the two things, and it sounded very classic, and imaging was unrevealing. I guess, how do you, the flip side of what was asked previously, manage a patient who has classic features of inflammatory back pain, but then MRI is negative?
So that's an interesting area to you, where Dr. Luco, where that clinical scenario you described, even from a classification criteria standpoint, happens quite a bit, where we estimate approximately 5% of patients who have disease will be imaging negative from an MRI standpoint, even using those very sensitive standards we're using at this point in time. So that's a little bit based on your clinical experience. I personally tend to treat those patients having spondyloarthritis, but I do know that in patients who are imaging negative, they have less of a treatment response, whether that due to them not having disease or having a different type of disease are questionable. I think you want to give them the benefit of the doubt generally to try to see what works from our armamentarium, but you do want to always constantly weigh those benefits and risks in your mind and have that conversation with the patient saying that these are the risks of medications. We know these medications, unfortunately, may not work as well for you, given your clinical scenario. What are your thoughts? And making that, shared decision-making process that we all have to go through in rheumatology, even more than some of our other patients, I think is the answer there.
Thank you.
We had one more question come through the Q&A. Do you screen for IBD in patients with suspected SPA? What is your threshold for colonoscopy? Would you obtain something like fecal calprotectin?
So great questions. The short answer is yes and yes. So colonoscopy is definitely so let's take Dr. Aluko's clinical scenario that you just heard, where it's a patient with inflammatory back pain, so has some suspicion for SPA. And they're coming in and they have some fairly vague complaint, GI complaint, where maybe they have a diagnosis of IBS or something along those lines. I do want those patients evaluated by gastroenterology with low threshold, hopefully, and me kind of pushing for colonoscopy on those patients. Where if we see evidence of inflammatory bowel disease, of course, that helps us really nail it down on the diagnosis of SPA, even in imaging negative patients. And if they say evidence of microscopic colitis, fairly extensive, that still increases my concern for SPA as well. So I do think colonoscopies are a useful tool, especially when the diagnosis is a little bit questionable and hazy or not fully coming to focus. Fecal calprotectin is a decent biomarker at this point in time, and probably our best commercially available. There are other ones that may become more prevalent over time for inflammatory bowel disease. However, if you cannot get colonoscopies, I do think fecal calprotectin is useful to have.
That's great. Thank you so much. I think that should wrap this up. Thank you for such a wonderful talk, Dr. Hwang. I will turn it over to my colleague, Dr. Atanuke Aluko, to introduce Dr. Ogdie. Thank you.
Hi. Hello, everybody. Welcome to the second half of today's session. My name is Atanuke Aluko. I'm a recent graduate from Washington University in St. Louis, where I'm staying on as faculty. I'm excited to be here today moderating this session. I would like to encourage us to make it as interactive as possible by just kind of overwhelming the Q&A section. And I am pleased to welcome to our midst today, Dr. Alexis Ogdie, who will be talking to us about psoriatic arthritis, which I think is a nice way to complement Dr. Hwang's excellent presentation. Dr. Ogdie is Associate Professor of Medicine and Epidemiology in the Perelman School of Medicine. She's also Director of the Center for Clinical Epidemiology and Biostatistics and Director of Penn Psoriatic Arthritis and Spondyloarthritis program. The mission of her research program is to improve outcomes in psoriatic arthritis by accelerating diagnosis, increasing the focus on meaningful patient-centered outcomes, and developing and advancing methods for precision medicine. Dr. Ogdie, thank you for being here with us today. The stage is yours.
Thank you so much. All right, so I'm going to share my slides here. So last year when I did this talk, we had talked so much about the features and kind of diagnosis and stuff that we didn't quite make it all the way to the treatment. So I kind of heavy loaded the treatments this time because there's so much to know about treatments in psoriatic arthritis. And I am very fortunate to follow Mark so that he's already talked to you about lots of the features. One of the nice things about pairing psoriatic arthritis and spondyloarthritis together is that they do share many of the same clinical features. You might just have more weighting toward a different set of features. So I'll talk about that in more detail. These are my disclosures. I will talk about medicines today. I will not talk about any one over another. There's so many things that I want to tell you about psoriatic arthritis that I can't possibly tell you all of them in 1 hour. If you have questions along the way, you can always feel free to email me and email me again if I don't answer the first time. What are some of the things that I would like you to know about psoriatic arthritis? I would like to have you know a lot about the physical examination, longitudinal assessment, and diagnosis. We're going to touch on that just a little bit today. I'd love to have you know a lot about the treatment because the treatments are different in spondyloarthritis and specifically PSA. Collaborative care. I'd like you to know about both the comorbidities and collaborating with other specialists like dermatology, for example, one of our closest collaborators, as well as GI and ophthalmology, as Mark has already kind of touched on. And then also imaging. So I won't go into too much detail about imaging today, but I'll give some kind of general pointers. All right. And because I would love to have you know so many things, I'm just letting you know here, there's some different, this is for both SPA, AxSPA, and PSA, some different kind of overview things. One of the nice overviews for PSA is this recent Nature Reviews Rheumatology kind of chapter on psoriatic arthritis. This kind of goes through everything soup to nuts, and it's recent, so it's kind of up to date with all of the therapies and everything. GRAPPA has a lot of different training videos, for example, and there's also young GRAPPA now for people who are interested in kind of getting it involved at the trainee level. And then Spartan also is a great training meeting as well. So consider those things in terms of getting additional information. If you're looking more for imaging on AxSPA, the Care Arthritis Education Portal has lots of options there too. All right, so with that, I'm going to do a tiny overview of PSA measures, and then I'm going to launch into treatments. And the reason is because you need to know about all these different options. You're going to hear about them or see them, and it's good to know something about them. But it's kind of like throwing mud at a wall. Some will stick this time. It might not all stick, and so you need to come back and you can either watch it again or learn about them through using them and reading about them. All right, so first, overview of psoriatic arthritis. How common is this? Well, the prevalence of psoriasis is actually quite common. It's around 2 to 3% of US adults. Psoriatic arthritis occurs in around 25%. There's estimates range from like 5 to 40%, but it's probably in that 25, 30% range of patients with psoriasis will develop psoriatic arthritis over the course of their lifetime. Actually, if you go to a dermatology clinic and you were to examine everyone in the clinic, you might find a good amount of undiagnosed PSA. At least 5 years ago, you would have. It was about 15% in one study where they looked at psoriasis patients in multiple clinics. Unlike AxSPA, which actually is getting closer to 1-to-1, and unlike RA, which is very female predominant, PSA is really an equigender, equisex, I suppose, diagnosis. So the male to female ratio is 1-to-1. Age at onset varies widely. So in AxSPA, we're really thinking about that young group. It has to be kind of starting before the age of 45 in general. Otherwise, you're really suspicious if it's later. In PSA, it's much more wide variation, but in general, people are in their 30s, 40s, or 50s when they're diagnosed. Psoriatic arthritis is highly heterogeneous. It's heterogeneous in both the way that we as physicians see the disease, so the different features, and I'll talk more about these in detail, but also the way the patient experiences the disease. Because this can involve the skin as well as the joints and the axial spine, you can get a lot of different impacts from the disease. So first, what are the different features of the disease? There's peripheral arthritis, enthesitis, or inflammation where the ligament, tendon, or joint capsule inserts onto the bone. And you just heard about this from Mark. And then dactylitis, or swelling of an entire digit, nail dystrophy, which goes along with the psoriasis, the skin psoriasis, spondylitis, as you just heard about. And then there's comorbidities, which I'll talk more about. In addition, how the patient experiences the disease varies quite considerably from patient to patient. Some patients have a lot of pain. Some actually have not much pain, and they have, some pretty swollen joints. Physical function may be more impacted in some than others. The family role. So obviously, if you have an age of onset in your 30s or in your early 40s and you're taking care of young children, that can have a significant impact. Additionally, if you have elderly parents that you're taking care of, that can also have a significant impact. Work productivity and the ability to kind of get to work and be productive at work. Your ability to want to socialize. If you're really embarrassed about your skin, you might be socially isolating instead of getting out there. Emotional well-being, we're going to talk more about. And then fatigue is a common symptom. I will tell you now that fatigue is multifactorial. So it can go up when a patient has high disease activity, but it's not always directly related to the disease. All right, so here are some of the clinical features that I just mentioned. We have peripheral arthritis, which you see here. Nail disease. So this person, if you are able to zoom in there a little bit, and I had a zoom picture, but I couldn't find it. So this is a patient who has pretty significant onycholysis. So they have like crumbling of their nail. And if you look closely, it's kind of lifting up at the edge. That's a pretty good feature for psoriatic nail dystrophy. So sometimes you ask patients, do you have nail problems or your psoriasis? And they'll say, oh yeah, I have lots of ridges or they're really brittle. That is not related to psoriatic disease. It's the onycholysis, so kind of eating away of the nails like this. It's almost like erosion of the nails, and pitting. So it looks like you took a pin and you literally just push right into the nail. Those are good signs to look for in the patient with inflammatory arthritis that's presenting to your clinic to know, could this be related to psoriatic disease in some way or another? Spine disease, which Mark just talked about extensively, so I won't go into detail. Here's a ACR image bank image for dactylitis, where this is really red and swollen. Most of the time it's not that red, but it is that swollen, and it's the entire digit from base to tip. Dactylitis is considered active when it is tender and swollen. There's a phase of dactylitis where the tenderness and the swelling kind of goes down, and they will often talk about feeling like they're walking on rocks, because it doesn't actually heal normally in many patients, especially if it's kind of left to over the natural course. It will heal with deformity. So dactylitis generally suggests a more aggressive form of the disease. If you see the dactylitis, you want to treat. It's also slow to resolve sometimes. NSAIDs can actually work really quickly for dactylitis. So think about that. Some patients, glucocorticoids, we'll come back to glucocorticoids later. We'd like to avoid those in psoriatic disease. And then this is enthesitis. This is someone's Achilles, and actually it's fluctuant there. You almost never see that. But the important thing here is that it's happening at where the Achilles is inserting onto the calcaneus. Some people come in with Achilles tendonitis and they think it may be related to psoriatic or disease or spondyloarthritis. It's not. If it's in the belly of the tendon, that tends to be more mechanically driven. It's inflammation where a tendon, ligament, or joint capsule inserts onto the bone or up to about an inch above. All right, just a couple pictures from the image bank as well to show you some differences. So this patient often is going to be misdiagnosed with psoriatic arthritis if they have prominent psoriasis, but they don't have psoriatic arthritis. They actually have osteoarthritis. In fact, this may be erosive osteoarthritis, a very common misdiagnosis. So how do we know this is osteoarthritis? Well, this patient has very discrete little Heberden's nodes. I usually say I can trace a circle around it. So if you can find these really discrete little nodules and you can kind of feel them, you can circle them with your finger, then that's going to suggest that it's more osteoarthritis. If you get hand x-rays, make sure to look at them yourselves. And this person, you would probably see a gull wing deformity that looks more like erosive osteoarthritis. So in this patient, we want some good solid evidence that this is really psoriatic arthritis before we circle through a whole bunch of biologics with this patient, because that's what will happen. You'll start them. They work for a little bit, like a couple months, and then they don't work anymore. And then you go to the next one and the same thing happens. That's not psoriatic arthritis, that's osteoarthritis. For some reason, they do get a little bit of benefit. And I don't know, none of us really know why that is, but that benefit is short-lived in general. If you put an ultrasound probe on one of these joints, you can see some of these ones that look a little juicier, but they have, again, those discrete nodules. You might see some synovitis, some very minimal synovitis, because in these patients, osteoarthritis is not truly non-inflammatory, it's mildly inflammatory. Anyway, this is a very difficult diagnosis to separate out sometimes, but just keep in your mind that it could be erosive OA and not psoriatic disease. This is a patient with rheumatoid arthritis. You see some wasting of her hand and then some fusiform swelling, often can be misconstrued as psoriatic arthritis or vice versa. Someone without kind of obvious psoriasis may be diagnosed with RA, and they may not be responding to some of the other therapies like the interleukin-6 inhibitors, for example. And then you kind of reassess and you're like, oh, actually, maybe you find the psoriasis on their scalp, or they called it dandruff or something. So important to search for the psoriasis in any patient with inflammatory arthritis. All right, so I went through a bunch of those domains. You might say, well, there might be certain categories of people that have X, Y, or Z, different phenotypes, but it turns out not. This is just a highly heterogeneous disease. It's kind of like Occam's razor. You're welcome to have as many different things. Hickham's dictum. You're welcome to have as many different things as you want. Same with psoriatic arthritis, and these can wax and wane. So in this particular study, we looked at, what are the different subgroups based on the different number of domain or the different domains that were involved. And you can see lots of tiny little slices of this pie. So plenty of people have different types of groupings. So there's not key subsets that we're able to define at this moment. And if your instructors tell you about the mole and right 5 subgroups, you say, Dr. Ogdie said we don't do that anymore. That's not really all that relevant anymore. And this kind of shows why, is that was something described in the 1970s. A lot of people still think about that. The keys are to identify axial disease and the degree of psoriasis. And we'll come back to that when we talk about therapy. As a rheumatologist, we often walk in the room and we think about the joints. And hopefully we also think about the skin. But sometimes we don't think about all the other things that might be affecting how a patient is doing or how they're responding to therapy. So this is just kind of a note to remember to ask about those things. So for example, our patients with PSA and psoriasis, moderate to severe psoriasis, have an increased risk for cardiovascular disease. And now having moderate to severe psoriasis is included in the cardiovascular risk stratification. So if they have CVD or high risk for CVD already on top of PSA or psoriasis, they should be getting on a statin or following up with preventative cardiology. So it's great to just go through your cardiovascular risk factors with them and refer if needed. Obesity is much more common in psoriatic disease than other diseases, including RA and axSpA. Obesity is common in the US, but it's particularly common in this patient population for reasons we don't totally understand. It does seem to precede the development of the disease, and we think it is a risk factor for development of the disease. We also know that managing obesity is also really important for the patient's response to therapy, and I'll come back to that later. Diabetes, there's an increased risk for diabetes in this patient population. As you can kind of start to get a sense, there's lots of metabolic conditions, additionally fatty liver disease. So as you're watching the labs come back from treatment monitoring, make sure to take a look at that glucose and take a look at those LFTs and think about the fact that this is a patient with PSA, so they have an increased risk for diabetes and an increased risk for fatty liver disease. Other things you've already just talked about, inflammatory bowel disease. The risk for IBD and PSA is similar, maybe slightly less than axSpA. And then the risk for uveitis is similar to axSpA. And in addition to uveitis, a lot of our patients have sicca symptoms and dry eyes in particular for unclear reasons, not sure how it's related. And we don't treat the disease to get the eyes better. That doesn't really help, but just asking about dry eyes is helpful. And then depression and anxiety are very common in our diseases. So for example, about 30 to 40% of patients with PSA reported anxiety, depression, or both in like circa 2018. And so since that time, we've had COVID, and we know that depression and anxiety have gone up. So it's really important to ask about these on your general review of systems at every visit. And I'm going to tell you why when we talk about therapies, there's some therapies that may increase that or may cause activation, similar to how a patient who is suicidal when they start an SSRI may become, activated in some way. So it's something really important to think about. Additionally, if they are depressed or anxious or both, they have a substantially lower likelihood of responding to therapy. So you can start your therapy, they're going to come back and say they don't feel very well, and they may even have just as many swollen joints, but certainly they'll have more tenderness. So identifying and seeking management for depression and anxiety are really important for our patients. And this is just to note that there is a really significant increase in suicide in our patients with PSA, even RA. But in PSA, the risk was 3 times greater than the general population. So pretty substantial. And that's also thought to be similar in psoriasis, where they get, the skin disease. When a patient gets better initially from the skin disease, they feel great. And then the worry as the psoriasis starts to come back, if a medication stops working or they lose access to their medicine, that can be very activating for suicidal risk or depression too. So just something to keep in mind. So what's my approach to mental health in practice? I inform patients about depression and anxiety being very common. I ask about symptoms of depression and anxiety. It's important to normalize it, that it's not just them. I think that's being easier now as mental health has been talked about a lot more, but normalize it, ask about symptoms, refer for further assessment and management. I tell patients just call and get on wait lists for a therapist because it might take 6 months. And in the meantime, talk to your primary care doctor. And then I defer treatment to a primary care doctor or a psychiatrist. I don't personally generally start the antidepressants because I can't be there to monitor it in the same way. But if needed, sometimes I very rarely will, but generally refer back to primary care. Another common comorbidity in psoriatic disease and axSpA is central sensitization and or fibromyalgia. So this goes a couple different ways. One is patients with fibromyalgia can be frequently misdiagnosed with our conditions because they have prolonged morning stiffness. They have a lot of characteristics of inflammatory back pain. The difference is that they generally don't get a lot better. They don't report feeling a lot better with movement as our inflammatory patients would. So our patients would like to move more. These patients may or may not, because they might say it exacerbates their symptoms the next day. It is really important to identify this because these patients will cycle through therapies and they'll keep not understanding the difference between the fibro or central sensitization and their actual inflammatory disease. They have to be treated separately. So recognizing it is half the battle. If you can recognize it, you can help them recognize the difference between the symptoms. And eventually over time, they get to know what's flaring. And when they call you for a flare and you have to figure this out over the phone, they can help you think through those symptoms of swelling and inflammation, as opposed to pain and like all over pain, that exhaustive fatigue, brain fog, etc. Sometimes they travel together too, so it can be difficult to separate out. When I talk to patients about central sensitization, again, I normalize it. I say up to 30% of our patients also have this. It's not necessarily any judgment on who the patient is or how they're, they kind of think sometimes that you're telling them they have a low pain threshold, and then they'll say, I have a very high pain threshold because I can tolerate this kind of pain. So common, you hear that all the time. But what I try to do is kind of take that discussion out or off the table and say, okay, these are the things we know. We know that your arthritis probably helps stimulate this central sensitization. Central sensitization also includes fatigue, disrupted sleep, high levels of stress, depression and anxiety I include within the stress, high levels of pain. And then this is usually accompanied by altered biomechanics. So if you have arthritis, you're feeling crappy and you don't exercise, the pain actually gets worse because your muscles get weaker and they're not supporting the joints. So physical therapy and exercise are so important for this, and none of them buy that initially, but you have to slowly increase the exercise. So aquatic therapy is really helpful. And then starting with 5 to 10 minutes of exercise, if they need to walk to the mailbox and back to get some exercise, that's fine. Just start somewhere and keep progressing forward. And then you have to deal with these other things like the stress, for example, depression, anxiety, in order for this to get better. So I usually say you have to target all of these things in order to start improving. And for fatigue, exercise is one of the ways we target fatigue. All right, I'm going to jump into therapies now, but I just wanted to kind of preface this by saying, when I talk about therapies, I'm talking about two pieces of the whole treatment plan. That's addressing the skin and the joints and also the treatment burden maybe. But all of these other things that we've just talked about also play a role. So concomitant conditions like diabetes, if your diabetes is out of control, you're not going to feel very good. Work, being able to do your job in a way that's, you feel productive is important. So a standing desk for someone with axial disease, for example, can help. Being able to interact with family and friends and have, low levels of depression or anxiety. So a therapist can sometimes help with this. Occupational therapy can help with this. Sleep physicians or psychologists or sleep psychologists can help with the sleep and fatigue sometimes. Physical therapy for exercise and muscle balance, and what I called biomechanics on the previous slide. And then nutrition. So having a healthy diet is important. We're running a dietary trial right now. We're not really sure what's the best diet, but often patients can find triggers. And so you say healthy diet is most important. If they want to try other diets, they may consider a Mediterranean diet. They could try a gluten-free diet. They could try autoimmune diet. Whatever they try, they need to stick to for 6 to 8 weeks. So it takes a little time. All right, so now let's launch into therapies. There are many therapies now, and we're still going. So in 2022, I think it was beginning of 2022, we already had UPA and risankizumab. So risankizumab, I think, was the most recent. So the first trial for PSA was back in 1990, which actually isn't that long ago. And the first biologic trial was published in 2002 with etanercept. So we have 5 TNF inhibitors, then we got an IL-12/23 inhibitor, then a PDE4, IL-17. I'm going to go through these in more detail. 3 more therapies, or 4, another one. So lots of therapies, and there's actually more to come. So there's 2 more on deck. So this is how I like to think about the therapies. This is I adapted this from the treatment guidelines paper from the American College of Rheumatology, which was published in ACNR and ANR in 2019. And Jasminder Singh is the first author. So since then, we've even had lots of updates. We, in those treatment recommendations, relabeled the oral therapies as oral small molecules. And we did that because none of the things in this box have disease modifying data. So they're typically called DMARDs, But in PSA, on the ACR and NPF side, National Psoriasis Foundation, we call them OSMs or oral small molecules, because there's no evidence available for them preventing damage down the line. So these include methotrexate, sulfasalazine, cyclosporin, luflanomide, and apremilast. All of those are oral. Then we have the 5-TNF inhibitors, which Mark just talked about: etanercept, infliximab, adalimumab, golimumab, and certolizumab. We'll talk about when you might choose one over another. Interleukin 12/23 inhibitor, ustekinumab. We have 2 approved IL-17 inhibitors for PSA and axSpA. That's secukinumab and ixekizumab. Brodalumab is approved and available for psoriasis. This is an IL-17 receptor blocker. It has essentially similar, equivalent efficacy to secukinumab and ixekizumab for PSA, but is not approved for PSA. This is one where they had some suicides and suicidal ideation in the treatment group within the psoriasis program. It's not totally clear that it's directly related, but because of that, it has a special REMS program where only dermatologists trained to prescribe this can prescribe it. So FYI, it's out there. It's probably even a little bit better for the psoriasis than the other ones. The next one that's on deck is bimekizumab. So this has been, they're working on some manufacturing issues, but this will probably be available in the next 6 to 12 months for psoriasis. The studies for PSA have been completed and they're and axSpA, so eventually those will be available too. So in the next year, you'll be seeing that. Abatacept is a CTLA-4 Ig. I'm not going to talk about that too much. That's really an RA medicine. It works a little bit for the peripheral PSA. It does not work for psoriasis, so it's not commonly used in PSA. In addition, we have JAK inhibitors, tofacitinib and upadacitinib. They're both approved for PSA and axSpA. Filgotinib is only approved in Europe, so I should probably take it off of here. It's not going to be moving forward in the United States. And then there's TYK2 inhibitor deucravacitinib. So it's not clear if this belongs in the JAK inhibitor category or not. That's another one you'll see in the next 6 to 12 months. It's going for approval for psoriasis right now and in PSA in the near future. So you'll be seeing some of that in our patient. That's an oral. And finally, guselkumab and risankizumab are both approved for psoriatic arthritis. Tildrakizumab is approved for psoriasis, but down the line may be approved for psoriatic arthritis as well. So wow, isn't that a lot of therapies? How do we think about these? Actually, before I go into detail about individuals, I do want to point out that the reason I said that axial disease is so important to identify is that only certain medicines work for axial disease. Those include the TNF inhibitors, the interleukin 17 inhibitors, and the JAK inhibitors. So only 3 classes available to your patients with axSpA and with PSA with axial disease. So if you have PSA and axial disease that is consistent with axSpA, you go with the axSpA treatment algorithm. All right. So let's talk about some of these individual therapies. Apremilast is approved for 2 indications in rheumatology. That's psoriatic arthritis and Behçet's for the oral ulcers. So this is a medicine that's actually an oral medicine that you take twice a day. It's very short-lived. The half-life is about 6 hours. It is thought to decrease inflammatory cytokines by blocking phosphodiesterase 4 through this pathway. Not totally sure. I don't know that anybody's convinced that they know for sure how this works, but it does seem to work through this pathway. The nice thing about apremilast is that in the label, it doesn't say you have to monitor labs. I will say I always monitor labs for everybody on any of the medicines that I prescribe, but every 6 to 12 months on this medicine. It is very expensive right now, but it is, and so most cases you would use something like methotrexate first because of insurance reasons, although the insurance companies have liberalized this a little bit so you can get this first line for the patient that has diabetes and fatty liver disease that you might worry about putting on methotrexate, for example. This is overall a mild medication in terms of efficacy, but also not so many serious side effects. The main thing is that it could increase depression. So again, that's why we're bringing up that depression piece and why it's important to screen for depression. So you have to counsel patients about that. And the biggest thing is there's a tolerability issue sometimes. So up to 20% of people will get diarrhea and or headache. Usually you know that right away because there's a starter pack, and the starter pack slowly increases the dose, and they usually start to get the diarrhea in that first pack. And then they go from the starter pack into the twice a day 30 milligram dose. And then if they're not tolerating it, they're probably not so likely to get used to it. And what I mean by not tolerating is that sometimes people have this like significant diarrhea, almost like IBD, where they can't leave the house. So stopping it though, it goes away fairly quickly. So just important to recognize that it might not go away if they're getting through the starter pack and it's still happening on that BID dose. It's probably not going to be a viable option. All right. By the way, please do use that question. I like the deluge of questions suggestion. So I have built-in time for questions here. All right, so moving on to a class of medicines that you will get to know very well because they're used across many of our diseases are the TNF inhibitors. So this is just to let you know that adalimumab and golimumab have very similar structures. Infliximab is very different. That's the one with the mouse variable region. Probably also why it has more antibody development than the others. It is a infusion. Golimumab is either subcutaneous or infusion. Etanercept, which is a fusion protein, and certolizumab, which is a pegylated molecule. So why would you like choose one over the other? Well, insurance company is generally the first thing because the insurance tells you what they're going to want. But there's some other things to know. So one is that if your patient has inflammatory bowel disease, the different ones you might use are different. So for example, if you have Crohn's disease, you may select adalimumab, infliximab, or certolizumab. On the other hand, if they have UC, you might choose adalimumab, golimumab, or infliximab. So their approvals are different. If you have uveitis, if the patient has uveitis, they may choose adalimumab, infliximab, or certolizumab. So it travels with the Crohn's one. And then if they have severe psoriasis, they may choose adalimumab, infliximab, or certolizumab. Again, the ones that travel along with the Crohn's disease ones. Now, it's important to recognize that the doses are different. So for example, certolizumab is twice the dose for psoriasis. If you have moderate to severe psoriasis, you're going to use 400 milligrams every 2 weeks, as opposed to for PSA, axSpA, you would use 400 milligrams every 2 weeks times 3, and then 200 milligrams every 2 weeks. And the same is true for some of these other ones. Make sure to look up the dose before you prescribe if the patient has one of these comorbidities. Up to date will tell you. Combination or not, whenever you give infliximab, you definitely want a combination therapy with methotrexate or sulfasalazine to help prevent antibody development. The same is probably true for the other ones, except for etanercept, which we'll come back to. We have less data for the other ones, though. Okay, dose matters again. Psoriasis, severe psoriasis, or moderate to severe psoriasis, IBD, and uveitis have different doses. All right, let's move to the IL-17 inhibitors. So I mentioned secukinumab and ixekizumab. These are essentially cousins of one another. Insurance companies tend to want one over the other because they have a deal with one of the companies. They really are interchangeable. The differences are in the dosing intervals. So in the loading dosing intervals. So secukinumab is weekly times 5 weeks and then once a month. Ixekizumab is every other week for up to 12 weeks if they have moderate to severe psoriasis, and up to I think it's just the first couple weeks if they have psoriatic arthritis alone. I don't know because I don't prescribe the psoriatic arthritis dose. If you have a patient with psoriasis and psoriatic arthritis, use the psoriasis dose for both secukinumab and ixekizumab. You want the higher dose. All right, so that's those two. They are IL-17A inhibitors. This is important because bimekizumab, the new one that's coming, is A and F. So whereas secukinumab or ixekizumab target one aspect, bimekizumab targets both. It's not totally clear yet whether that makes a big difference. It may have a difference for the psoriasis. Down here I have brodalumab, which I mentioned is for psoriasis only. That is an IL-17 receptor A blocker. So it kind of functions a little differently. All right, so one of the questions is, do you start a TNF inhibitor or an IL-17 inhibitor first in your patient with psoriatic arthritis? There's not a right answer, but this is a trial. There are two trials, from one with secukinumab versus adalimumab, and another one with ixekizumab versus adalimumab. And what you will see for both is that essentially, if you just look at the joint response, they're essentially identical. So this is the joint response for ixekizumab versus adalimumab. This is the joint response for secukinumab versus adalimumab, maybe a tiny advantage, but not statistically significant. When you look at the psoriasis, that's when things really separate out. So the IL-17 inhibitors are undoubtedly better for psoriasis than the TNF inhibitors in general. So if a patient has more moderate to severe psoriasis, you may start first with an IL-17 inhibitor. You don't have to. Sometimes the insurance company tells you no. So you'll go by the formulary in general, but you can start with an IL-17 inhibitor first in that case. With biosimilars coming soon, I don't think that'll be an option that much longer, but we'll see what happens. Other thing to know, let's say you start an IL-17 inhibitor and your patient's skin flares, like massive flare. That might tell you that they don't have traditional plaque psoriasis. They may have more of an eczematous type skin disease, or maybe they have eczema. Eczema sometimes flares with the IL-17 inhibitors. So if your patient calls and says, I just got a really bad, my skin just got way worse, think eczema, stop the medicine, try something different. For the TNF inhibitors, you can get a bad skin reaction, also stop it. That can be more of an allergic type reaction. All right, ustekinumab is a P40 subunit of the IL-23 and IL-12 receptors. So here you see P40, it's a shared portion of the IL-12 and IL-23 receptors. So basically you're getting signaling through both, or dampening signaling through both, I should say. So it's kind of interesting because you would think that, again, going through 2 makes a difference compared to going through 1. But what I'm going to tell you is that in the IL-23 specific inhibitors that signal through P19, they're actually better for the skin in head-to-head trials. So it's kind of an interesting phenomenon that we don't really know how to explain well. Ustekinumab works very well for the skin. It's dosed every 12 weeks, which patients love. So it's 0, then 4 weeks, and every 12 weeks. It's more for mild PSA. So they don't have much, or maybe it's ustekinumab plus methotrexate is a good combination. But it's generally not going to cover the more really robust PSA. So now let's talk about the P19 subunit inhibitors. Again, this is specific to interleukin 23, doesn't cover that IL-12. They're fantastic skin drugs and actually quickly becoming one of the first line agents for psoriasis. So if you see patients referred to you with psoriasis, they may have already experienced a 23 inhibitor and they're coming to you for a new psoriatic arthritis, let's say. So these are very common, and that's guselkumab, risankizumab, and then tildrakizumab. The interesting things about these drugs is they're very safe in general. So if you look at the safety profile in terms of the adverse events seen in these drugs, there actually are often numerically more events in the placebo group than in the treatment group. And you don't have to specifically worry about, so there's some infections, but in both groups, the placebo and the treatment group. And we always tell people about the increased risk for infection still with this, but it's not totally clear that that's a significant concern. So not a lot to really think about with these medicines in terms of major side safety issues. So that's kind of nice. There's been a couple trials. I can't remember if I put those in. Yep. So this is the guselkumab trials. The risankizumab trials look very similar. They were just presented or published recently. So I'm sorry that it was presented at EULAR 2021 and EULAR 2022. Sorry, I didn't update that slide. So anyway, but it's been published now. And what you can see is that this is in patients with psoriatic arthritis, half of which are on methotrexate at baseline. About a third in this trial are also on, have experienced TNF inhibitors before. So you can see that it does significantly differ from placebo. What I'm going to point out briefly is that in these trials, they use Q8 weeks is the approved dose. So it's 100 milligrams at baseline at 4 weeks, and then every 8 weeks for PSA and psoriasis. But in these trials, they also used a Q4 week arm. And this one was associated with radiographic inhibition. So there was a statistically significant decrease in radiographic progression. That was not true in the every 8 week arm. I find in practice, this is a off the record, on the recorded line comment, is that sometimes if the patients don't do well every 8 weeks, I may occasionally try to increase Q4 weeks because it was equivalently safe in the trial design. Don't quote me on that for now, although I've just quoted myself. But in any case, I would stick with it every 8 weeks. This again is good for someone maybe earlier in disease that has less significant joint involvement at the time, but it's great for the skin. So really good for the patients with moderate to severe skin disease. All right, last class, JAK inhibitors. So there's tofacitinib and upadacitinib. You may know baricitinib from the RA space. That's not approved for psoriatic disease or axSpA. But both tofacitinib and upadacitinib are. You know that JAK inhibitors kind of inhibit across a broad range of cytokines, so they're kind of more of a broad hit to the inflammation. There's also a class of medicines that's coming that I mentioned called TYK2 inhibitors. So you see TYK2 right here. That is called deucravacitinib. There's others of these that are going to come down the line too. The safety profiles look a little bit different in the trial, so that's kind of interesting. But with it being relatively early, we'll see down the line if that's true or not. But anyway, something to watch this space. So what are some of the things that we, in PSA, that's some early data from the phase 2 study from PSA. I didn't mean to include that in here. One of the things that I did want to raise was the issue of the JAK inhibitors in PSA. So one of the things you need to know is that among patients with high cardiovascular risk, we might avoid these medicines. Additionally, in the label, it says you have to use these medicines after a TNF inhibitor. So you can't, according to the label, use these as first-line agents. So they conducted a study in patients with rheumatoid arthritis, age 50 and older, who had at least one cardiovascular risk factor. And when you look at this patient population, they had pretty high cardiovascular risk overall. And they found that across everyone, there was numerically more events, cardiovascular events, stroke, VTE, and cancer in these in the patients who were using tofacitinib compared to either adalimumab or etanercept. So that's important to know, because if you have patients at high risk for one of those, you may not choose one of these therapies. Or more so, you're just going to have to counsel on this. The actual number needed to see a difference is 500. So you'd have to treat somewhere between 250 and 100 and 500 patients with tofacitinib versus the TNF inhibitor in order to see one additional event. So these are very rare. You do see more events in the 65 plus. So I tend not to use these medicines for people age 65 and older, or those with high cardiovascular risk. So something to be aware about and to counsel about. Again, that study was in rheumatoid arthritis. We don't have those studies for PSA or axSpA. And those patients on average tend to be younger than rheumatoid arthritis patients and generally have less cardiovascular risk, but you still have to counsel about it because it's in the label. And this is just to show that there was a non-inferiority study. So while you would say this isn't statistically significantly different, it crossed the line that they considered meaningful. All right, so as I wrap up, I'm going to talk about treatment guidelines or recommendations. So we have the ACR MPF guidelines from 2018, published in 2019. And then we have the GRAPPA guidelines from 2021, published just recently in 2022. So these are in the Coates, Laura Coates is the first author, Nature Reviews Rheumatology. It's now published EPUB ahead online, and it's available for free download. So what are some things that are different from previous guidelines or other guidelines? One of the things I like about this set of guidelines is it tells you what you need to assess, and then tells you how to think about picking a therapy based on what you assessed. So for example, you would find out, does the patient have peripheral arthritis, and essentially how severe is it? Severity psoriasis, do they have enthesitis, do they have dactylitis, do they have nail disease that's bothering them? Do they have axial disease? Associated conditions, meaning IBD or uveitis, and then comorbidities that might influence treatment selection. And actually, this is the early figure. So in the new figure, it's flipped the other way. So you look down, which is kind of nice. But in any case, let's say they have axial disease. Axial disease and severity of psoriasis are going to drive your therapy selection, as well as the IBD and uveitis. So let's say they have axial disease. You would look across and see which ones are eligible for axial disease, which would be good for psoriasis, and then what is good or not good for IBD or uveitis, and you would choose the best therapy. We've created a decision aid to help with this and kind of automate this through like a questionnaire. It's currently being transferred from one website to another, but eventually we'll share that again. Just a brief word on combination therapy. We do it frequently. So we use a lot of these medicines that I just talked about in combination with methotrexate or sulfasalazine or leflunomide, or even apremilast if you can get that paid for, because that tends to be very expensive. I'm just going to show the SEAM PSA data. This was a trial published in 2019 in A&R. Philip Meese is the first author, where they examined the effect of adding methotrexate to etanercept versus etanercept alone versus methotrexate alone. And if we look at minimal disease activity, which is a good measure of getting someone to low disease activity, you see that patients who were on etanercept did better than patients on methotrexate alone. But it's interesting that adding methotrexate to the etanercept didn't do much. And we're talking like full dose methotrexate. The mean dose was 18.8 milligrams. So 20 milligrams is really where we're shooting for most of the time. So most of them got there. So despite that, didn't add a lot to etanercept. We may see the same with the other TNF inhibitors too in terms of efficacy. With what we don't know is if you extend it as long-term, does it prolong the life of the drug? And in some of the studies that we've done, we've seen that it does seem to prolong the life of infliximab in particular, and maybe adalimumab too, but something you can consider. All right, treatment strategies. We talked about whole patient management being really important. I've already talked through this figure, so I won't go through in detail again, but it's good to address these different aspects of the disease with the patient. Additionally, treat to target strategy can mean many things. So in RA, it means measuring a DAS28 or a CDAI. I'm going to talk about some of the targets that we use in PSA, but I would just say creating a goal with a patient and measuring and monitoring that goal at every visit and making tweaks or changes to get to that goal. So I'm going to broaden treat to target, in my opinion, and say that, let's say the patient wants to get, so I had a patient the other day she was a basketball player and she's now 35 and has had really bad PSA. And we're finally getting it under control. And so her goal is really to get back to athletics and doing more athletic activities. So while we're tweaking her therapies to get her down to 0 swollen joints, if that's possible, or at least manageable swollen joints, we also made a plan to get her back on the basketball court over a period of time. So starting with physical therapy, augmenting that with starting to increase walking. Then the goal would be to do some, just basic stuff with the basketball, making sure her hands can handle that. So making slow progress toward her goal, and we're working on that together so that I am moving toward what she needs, as well as what I typically think about, which is how many swollen joints do you have? And this is really where the value of patient-reported outcomes comes in, is we can see how the patient is doing, and they integrate all those things into their scores. So when her rapid 3 score was 11, it's not just based on her tenderness and swollen joints. It's based on, I would really like to be playing basketball again, and I'm not there yet. So her 11 is going to be different than the patient who is disabled, let's say, in a wheelchair. That an 11 might be really good for that person, maybe the best that they can achieve. So we can get her down to a 3 or a 1. So having some marker is nice to have a numerical way to place on how is the patient doing, how is the disease impacting their life. And these are so easy to do, and I say that somewhat lightly, in that it takes forever to get them into your EMR, but if you have Epic, you can easily do that and attach that to one of your different, into your visit. So my patients get a rapid 3 in their app before coming in to see me. I'm going to pause for a second and take a question that I just came into the Q&A, which is there a role for measuring anti-TNF antibodies guide management in PSA? I've always said no to that, because I would say follow the patient's symptoms. If the patient's not doing so well, consider, increasing the dose of the TNF if you're able to get that approved, or switching to a new therapy. But there was a recent study in JAMA that was from Norway, and they took patients from a variety of different diseases, including IBD, RA, axSpA, PSA, psoriasis, and they use anti-drug antibodies and drug levels in order to monitor, how people were doing and make therapeutic changes. And the people in the monitoring arm did do better. So it still blows my mind a little bit, like how would that influence things, but I suppose it's data to say, all right, this patient, when the patient comes in and they're having kind of an off day and you say, well, maybe that's just an off day. Maybe that informs the fact that they're doing better. Now, let me caution you though, because those antibodies are expensive and not all insurance companies pay for them. Additionally, let's say you have a positive drug antibody and they're on adalimumab. Their insurance companies can say, no way, I'm not paying for that anymore. That has happened. So, and that's not an uncommon occurrence anymore. So I think very cautiously before ordering them about the downstream implications. And if you really need them, and if you're truly going to make a therapy change, if it's positive. So with any test, I think that's always true, but always know what you're going to do with the result and make sure it's actually going to change management in either direction, if you, depending on what you see. All right, I'm going to skip ahead of the PROs, but just so you know, there's a couple different PROs you can use. The RAPID-3 is one of the most commonly used in the United States, and we often use it across diseases. This is the RAPID-3. It's got 10 questions about functional elements. It's got 3 questions that are not scored about sleep, anxiety, and depression. And then there's a pain question, 0 to 10, and a global question. And this is where, considering all the ways in which your illness and health conditions may affect you at this time, i.e., I can't play basketball or I can't walk, please indicate how you're doing in a 0 to 10. So it means something different to every patient, but you're looking at inter-patient changes. So this score is the sum of the 10 items here, plus the global and the pain. I'm sorry, this is divided by 3. So you get a 0 to 10, 0 to 10, 0 to 10. And you can add them together and think about it in a 0 to 30 scale, which is how I think about it, or a 0 to 10 scale. Now, the other one that you can use is the PSED. So the PSED is a psoriatic arthritis specific questionnaire with 12 items, results in a score of 0 to 10, and asks how they're doing on all these different domains. I like this one because you can see individually what's bothering the patient, and so it's really nice. It's hard because if you're seeing patients with XPA, then a patient with RA, and a patient with PSA, you have to know to give it to that patient, but just something to be aware of. It's very strongly correlated with the RAPID-3 though, so you don't need to use this one. The RAPID-3 is often, I think, sufficient. Some people might argue that. All right, so what are the targets? So your target could be the patient-reported outcome, but the other targets that we follow are the MDA, the minimum disease activity, or the CDAPSA or the DAPSA. So I'll talk about both. The MDA means that the patient, you're in minimal disease activity if you've achieved 5 of these different 7 domains. And so if you have 1 or less swollen joints, 1 or less tender joints, 1 or less tender entheses, psoriasis body surface area of 3% or less, where 1% is one of the patient's palms. So for example, if they have some plaques of psoriasis and you could put them all together in the palm, how many palms of psoriasis do they have? 3% or less is considered meeting this criteria. Most patients don't feel good at 3%, by the way. That's a little high. A patient pain assessment of 2 or less, patient global assessment of 2 or less, and a HAC of 0.5 or less. These are all components of the RAPID-3, and the HAC, you can get the function score. The MD HAC kind of translates, the RAPID-3 HAC can be translated to the MD HAC for a kind of general assessment. And there's an alternative to using the HAC, which is using the PSED. The joint exam that we're going to do is the 66-68 joint exam. So you may learn in your rheumatology, with your rheumatology group, that about doing a 28 joint count. That's for rheumatoid arthritis. The asterisks are next to the 28 joint count. So this is the 68 joint count. It includes like the TMJ, which can be involved, the AC joint, the SC joint here, which cervicolavicular, which can actually get swollen sometimes. Elbow, these ones are included. The DIPs are different. The ankles and feet and toes are also included in this joint count. And the hips. So the hips can't be swollen. You can't see swelling in the hips. The hips are pain on range of motion of the hip. So it's just tenderness. So that's the joint count we use in both of these different MDA and DAPSA. So the DAPSA is a simple sum of your tender joint count, your swollen joint count, patient global, your patient pain, and your C-reactive protein. And then these are cutoffs for low disease activity and remission. Most people don't have a CRP at their visit, so we use instead the CDAPSA or the clinical DAPSA. And so we just sum these 4 elements, the remainder of the 4, and slightly different cutoffs. But the good news is it's extremely strongly correlated with the DAPSA, and it turns out you probably don't really need the CRP. So this is the one that we capture. And if you noticed, it's 4 of the 7 elements of the MDA. So you can essentially get both. Just make sure you're also thinking about the psoriasis. All right, final comment, just going back to my patient who wants to play basketball. It's really important to know what is bothering our individual patient. And if you ask individual patients what they want an effective therapy to change for them, they say all kinds of different things. This is a study that we need to publish, but have not yet done that. But in any case, there are many different things that they say, and you can build a treatment plan that gets to that. So make sure you're thinking about what the patient needs and moving toward that. All right, so management of PSA has come a long way. It's really important to assess all the different domains that are important to choosing a therapy, and then also assessing what's important to patients. Tailored management, tailoring the therapy to the patient's disease manifestations as well as their goals is really important. And that's one form of personalized medicine. So we can already do personalized medicine in PSA given this heterogeneity. And then there are more trials that are needed to really inform management strategies. Some of these are ongoing now, so we'll be learning a lot in the next few years. All right, with that, I will stop and open for questions.
Thank you so much, Dr. Ogdie, for such a wonderful talk in such a short amount of time. I would encourage us to continue to post questions, the Q&A section of this. While we're waiting, I have a quick question. So how would you approach a patient who has psoriasis limited to just the skin, say managed on just topical therapy, and has imaging evidence of inflammation, either synovial, enthesitis, that kind of thing, but is asymptomatic?
That's an excellent question. Yeah, so that's something we're studying right now, is we don't really know what that means. So actually, one of the trials we're doing right now is taking patients with psoriasis and subclinical joint inflammation or enthesial inflammation, randomizing them to therapy and following them forward in time for the development of clinically overt PSA. About 25% of them will go on to develop clinically overt disease, but at this moment, we don't have evidence to suggest that we should treat them. So you want to treat the symptoms. Now, on the other hand, what also happens sometimes is you see this patient with psoriasis generally you're seeing them for some reason, but they may have like a swollen joint, let's say, and they're like, I'm fine. I don't need anything. I'm fine with just my topicals right now. Actually, the common scenario is my dermatologist really wanted me to see you because they think that this is a problem. I don't think this is a problem. You're like, you're developing damage in that joint actively. So I try to encourage them to use a treatment that's going to cover their psoriasis so they get the benefit for that. Now, occasionally though, NSAIDs are enough. And so if NSAIDs are enough, and monitoring your NSAIDs is still just as important as monitoring any other therapy, because they can cause, creatinine elevation, LFT elevation, so it's still an intervention, but doing that is so helpful too. So you don't have to jump to a biologic therapy or an oral therapy, oral small molecule. You can try just NSAIDs first as well as their topicals. But you want to keep an eye on that patient to make sure that they're not developing damage, get x-rays at baseline, and then you may get an ultrasound to see like, where is the inflammation? Sometimes you can be fooled by just mechanical things and they don't really need that. But it's like decoy, I'm pointing to my thumb because like decoy veins, for example. But it's important to know, get a sense of what's going on. And then you can go along with the patient for a little while and, monitor, but make sure you're monitoring that they're going to come back.
Thank you. Another quick question. So some patients obviously develop psoriasis like way ahead of time before they develop the arthritis. And there are some risk factors for that. Is there a way to preemptively, if you see a patient that kind of looks high risk, prevent that progression from happening?
Yeah, that's a good question too. And that same kind of thing in this trial, we're also allowing people in who just have high risk. So, and we're defining risk based on risk factors we've identified in the, in like epidemiologic literature, for example, having nail disease. So if you have nail pitting or onycholysis, you probably have ongoing inflammation in the enthesis there. So if you put an ultrasound on, a lot of times you can see inflammation extends into the joint. So it might be an early harbinger that you're starting to have that type of inflammation that's needed to cause arthritis. Being obese is another one. And then the psoriasis severity. So patients with moderate to severe psoriasis are more likely to develop PSA. Having depression actually is not one we're using in our trial, but that's associated with increased risk for PSA, and not quite clear why. Maybe the stress levels. And then having uveitis or a first degree family member who has PSA or axSpA, then that patient is probably more likely to go on and develop overt disease. But again, there's not evidence that treating them now prevents the progression, but that's what we're hoping to understand with some of those studies that we're doing.
So I have a question here in the Q&A. It says, so has it been shown whether treating psoriatic arthritis with some of the medications you mentioned reduces the risk of CVD risk or reduces their CVD risk? And they put in here excluding the JAK inhibitors.
Great question. So one of the interesting things about this is that we can't really randomize it. You have to have thousands and thousands. So in that trial I talked about, they had 4,000 patients. So, and you're barely able, you can't see statistical differences between those two active therapies. So we can't conduct trials large enough to understand this for sure. So we don't know for sure that treating patients with psoriatic arthritis with certain therapies reduces cardiovascular risk. On the other hand, there's some imaging studies that suggest that treating with a TNF inhibitor reduces inflammation in the aorta, for example, on PET CT. So observational studies, and when randomized, actually phototherapy did something similar, or like was a similar degree as adalimumab. So it might be that treating the psoriasis in general has benefits. There's been some observational database type studies that have suggested that TNF inhibitors reduce the risk for cardiovascular disease. So there's a lot of evidence pointing in that direction, but not conclusive. So I don't generally tell a patient that I'm going to treat you to reduce your cardiovascular risk. I say it could help, but we don't really know that for sure. We think that probably in particular getting the psoriasis burden down is really important, is likely important, but again, not conclusive. And of the therapies that have some data around that, it's like the TNF inhibitors and the methotrexate. Again, probably because we have so many people on those therapies, we can actually demonstrate a difference. You may see something similar with ustekinumab or IL-17 inhibitors or some of the IL-23 inhibitors. We just don't have enough patients in large data sets to study that at this time. And that's one of the theories about the tofacitinib thing, is maybe tofacitinib doesn't actually increase cardiovascular disease. It's just that the TNF inhibitors prevent it. So there's, alternative interpretations of those facts as well.
Thank you. Another question, using ultrasound, would you consider grayscale hypertrophy as a sign of inflammation, or do you think Doppler signal or hyperemia is more a surrogate for inflammation? And would you treat someone who just has like grayscale hypertrophy?
That's a great question. And again, I'm not sure there's a definitive answer for it. There was an abstract presented at ACR, I think last year, that looked at those findings, and they found that powered Doppler was more likely to be associated with active disease as opposed to the grayscale. But again, it was one pretty small study with, I think, like 30 patients or something. So this is very early. So I think you have to take into account the whole clinical picture when making that decision.
Thank you. One last question. Do you ever, what would be your approach to like step down therapy in a patient who you think has achieved remission?
Step down therapy, you said?
Yeah, or I guess, long term, like if a patient wanted to taper down or wean therapy.
There's a lot of interest in this question, and some kind of early studies that have been addressing this. So we don't have solid evidence or like recommendations at this time, but there are some studies, I think, from Japan that were presented recently that suggested that having the dose, so just like going from 50, let's say etanercept 50 milligrams every week to 25 milligrams weekly, I think they did, or maybe they would do 50 every other week. I can't remember, but they, the patients were able to do just fine and then eventually come off. So I usually tell my patients that they should be on therapy in remission for about a year, 1 to 2 years, I usually say, and then we can start coming off, because the studies that have been done have suggested that if you have low disease activity when you stop the therapy, they're going to flare. It's just a matter of time. So if they're in the remission for an extended period of time, you can come off. I generally space. So I do, let's say, etanercept every 2 weeks instead of every 1 week, or adalimumab every 4 weeks, 3 weeks. I kind of have them just start spacing it out and seeing if they're doing okay. If you're getting the sense that they're getting more stiffness, pain, or swelling coming back right before that next dose that you've spaced out, that suggests probably now is not the time to do it.
Thank you so much, Dr. Ogdie. This was an amazing session. We all learned a lot. I think I can confidently speak for everybody when I say that. I think there's supposed to be a survey that attendees are supposed to fill out. It'll take about 5 minutes and it's completely anonymous. So if we could please fill it out. And so the next session is scheduled for Monday, July 25th at 10:30 a.m. to 12:30 p.m. Eastern time. And it's going to be, the first part of it is going to be a talk on crystalline arthritis by Michael Pellinger. And then the second part is going to be MSK radiology with Dr. Beth Jonas. Thank you so much, everybody. Thank you so much for attending, for your questions, and thank you to the presenters for such wonderful, wonderful, wonderful talks. Thank you. Bye.